It's my sincere pleasure today to be with a wonderful group of panelists regarding review of some GI cancer cases. My name is Dr. Kathy Ng from Vanderbilt Ingram Cancer Center, the David H. Johnson Endowed Chair in Surgical and Medical Oncology, and the co-director of the GI Research Program. Today we have some wonderful panelists, and we'll just go around and have them introduce themselves. So please introduce yourself, Carrie Siegel.
Hi, good afternoon. My name is Dr. Carrie Siegel. I'm an abdominal imaging radiologist at Washington University in St. Louis.
Hello, everyone. My name is Al Benson. I'm a GI medical oncologist at Northwestern University and the Robert H. Lurie Comprehensive Cancer Center, where I serve as one of the associate directors.
I am at Emory University and Winship Cancer Institute. My focus is primarily complex upper gastrointestinal and hepatobiliary surgery, and it's a pleasure to be here today.
I'm Preetish Patel. I'm an associate professor of radiation oncology at Emory University. I work closely with Dr. Kubi. Glad to be here today and to discuss some good cases.
So now we have a young female, 35 years old, diagnosed with Down syndrome, who presented with a 3-month history of symptoms and CT scan imaging showing a 9.2 centimeter rectosigmoid mass with 4 liver lesions. Biopsy of the liver confirms metastatic adenocarcinoma from the colon. She presents to her clinic with her legal guardian to discuss treatment options. Now, she originally presented with a 3-month history of abdominal discomfort, 20-pound unintentional weight loss despite a good appetite, change in bowel habits with increased frequency, 5 to 8 bowel movements a day, and watery mucus output, as well as intermittent hematochezia. Her performance status is 2. She ambulates without difficulty and is active throughout the day, but she's very dependent upon her sister and mother for her ADLs. She's able to answer some questions, but is unable to understand her diagnosis. She believes she is intoxicated with something she ate. Her sister tells you that she's very afraid of needles and describes the patient as a child in an adult's body. There's no other medical history. Social history is non-contributory, and family history is also non-contributory. In January, she underwent diagnostic imaging, noting this large mass with liver lesions that are as big as 6.5 by 7.5 centimeters in segment 7, 3.1 by 3.7 in segment 2. And I think we're going to go over some of this imaging, but another lesion was 3.5 by 5.1 and 2.5 by 3.6 in segment 5, and then 0.9 by 0.8 in segment 4B. CT scan of the chest demonstrates a 0.3 centimeter right lower lobe nodule, which is new as of 3 months ago. And once again, the liver biopsy has been completed, which confirms colon carcinoma is the primary tumor. She does not have medical insurance and is transferred to Safety Net Hospital for further care. Her colonoscopy was recommended by GI to evaluate for impending obstruction, but is not covered by insurance, so has not been performed yet. And her baseline CEA is 53. Dr. Siegel, can you please comment on these images of her pelvis?
Sure, we have post-contrast CT images here, and you can see in the region of the rectosigmoid colon, there's this large, irregular, thick-walled mass with even some sort of mild ectasia or dilatation of the rectosigmoid. And if you look at all the tissues around the bowel, there's sort of engorgement of the fat, and there's multiple vessels, tiny lymph nodes. The sort of presacral soft tissues are edematous. The lymph nodes are all small. I don't see anything that's overtly enlarged, but everything's sort of engorged, and the fat is all indistinct in this sort of perirectal area.
Thank you. Now, can you comment about the liver imaging?
Sure. This is arterial phase imaging, and we can see that there's a very large lesion in the right lobe of the liver and a fairly large lesion in the left lobe of the liver on the 2 imaging sequences that we have. Likely the patient's known metastatic disease. You can see on the right image, there's a little bit of capsular retraction of the liver and maybe a little bit of ascites.
Thank you. So Dr. Kubi, we've got a young woman here with Down syndrome, who is scared of needles. Her sister's her primary caretaker. She's unable to get a colonoscopy for some reason, but I'm presuming she's able to come in and see you. How would you recommend proceeding with this patient? Do you have any concern she's had unintentional weight loss? Is this a patient that you believe should go straight to systemic therapy, or would you like to scope her in your office, or how would you like to proceed?
Yeah, from the standpoint of the colonoscopy, she needs one. I understand there was a financial reason why she didn't get one. Now that she's in the safety net hospital, that should be done while she's in the hospital to figure that component out. This is essentially you're treating a child, so the person's not going to be as verbal or as complete about their symptoms. So you want to make sure there's no disaster. Having said that, it looked like the lumen was fairly patent on the imaging, at least from the cuts that we saw. So there might be reason to believe that this is more functional rather than obstructive in nature for bowel activity. But if she can get by without a diversion, that would be ideal if they're on systemic therapy. As far as the distribution of liver tumors, based on the description in the case, 1 in 7, 1 in 5, 1 in 4B, 1 in 2. So they're basically at every zip code of the liver. So, and given the size and the location and the number, certainly a pre-op systemic, or I should say systemic first approach would be appropriate, and then kind of see where the dust settles.
So Dr. Benson, this patient, how would you like to proceed given the extensive disease and her current symptoms? And it states that she is having pain and frequent diarrhea, but it doesn't look like she's obstructed. And do you want any additional next generation sequencing? And what would be your initial approach to this patient?
Yes, so Dr. Ang, I would also stress here, this is example of disparities. And certainly with COVID, it's just come front and center, and what we've known for generations about disparities. And what we hope is that we are more fully addressing such, so that patients who financially are in a very difficult situation can have appropriate health care. And as Dr. Kobe mentioned, she should receive a colonoscopy. It's an essential component of her care. Likewise, it is critical that we have at a minimum the genomic determination that includes at a minimum MSI, RAS mutation status if she is RAS wild type, HER2 testing, as well as BRAF testing. And that's the minimum evaluation she needs to have to inform her treatment decision. It's going to be important, I think, to discuss with the people who are responsible for her well-being, genetic counseling. Certainly her sister and mother need to have this discussion, because they both should have colonoscopies, but also the consideration of genetic counseling. So all that needs to be discussed appropriately. Unfortunately, it is not likely she is curable. We also know that if we begin treatment with systemic chemotherapy, we have good examples of people getting great response, both at the site of metastatic disease and with the primary. And so most people would consider beginning with CAPOX or FOLFOX. In her situation, that might be a difficult decision. She might not be comfortable wearing an infusion pump for 46 hours. So this is something that would have to be carefully addressed with her sister and mother. But if we went with CAPOX, would she be able to be compliant with taking the capecitabine. So there are a lot of discussions that have to occur, but I think in general, you would consider FOLFOX or CAPOX with or without bevacizumab, and then the genomic determination may give guidance, excuse me, if she did by chance have an MSI tumor, that given recent results, another New England Journal of Medicine publication where we would start with immunotherapy based on those results. And that perhaps, even though she may be very fearful of needles, but an immunotherapy regimen would be perhaps the easiest for her to undergo. So, and nowadays we can get MSI very quickly. So before a treatment decision, she needs to have MSI testing done in short order.
Thank you. Dr. Patel, assuming that we give her neoadjuvant, I'm sorry, not neoadjuvant, but palliative chemotherapy with FOLFOX or CAPOX or FOLFIRI, if she has adequate response and her tumor remains solely within the liver, do you see any role for any type of stereotactic radiation therapy for this patient?
Yeah, I think a great question. This comes up often at our tumor boards. We would, of course, hope for a wonderful response in all these lesions in the primary as well. I think in general, we would defer to Dr. Kuby and his team about if surgery were feasible, to go that route first. Sometimes maybe a combination approach where surgery is feasible in many areas, but for example, if the caudate lobe is in particular a challenging area, then maybe we do SBRT or a combination or some other type of liver-directed therapy. And then the other question that comes to mind is, do we treat the primary with radiation if surgery is being considered there? And often we're sort of using the same criteria we would use for somebody who doesn't have metastatic disease. So if it truly is a sigmoid tumor, probably no radiation would be recommended. But if it were more a rectal tumor, certainly if there's concern about, again, the circumferential resection margin, this is sometimes an ideal situation to think about short course.